to go ahead and start and be prompt. We've got a lot of content to go through. So good morning and welcome to Steward Healthcare Works educational series, and specifically talking about risk adjustment and CPT II coding. Again, this is for both physicians, providers, as well as for staff today. We're going to be focusing more on staff today than physicians. However, for those physicians who are on the phone or on the Teams meeting, I have no doubt that you will get all the information that you might need. Just to let you all know, this session is being recorded, and slide decks as well as appendixes for information distributed to the group after the meeting. All right, next slide. My name is Dr. Donna Milovitz, and I'm the Regional Vice President for the network for Utah and Arizona. And we're really pleased to be able to supply both CME and also coding credits for those of you who are certified coders on the call today. Again, our learning objectives are really to define risk adjustment, as well as explain on how to implement, monitor, evaluate, assess, and treat your patients for chronic conditions, as well as code appropriately for them. If you have any questions for CME, please contact Carrie Roberts at steward.org at the information noted on the screen. Next slide. Again, we have both CME and MOC points for both adults and pediatricians that are available. Next slide. And that for medical coders, again, the AAPC will honor a 1.0 CEUs for any live event for CME. Again, the website below is where you need to go to make sure that you receive your credit for this. Next slide. And then for the providers on the line, again, this is the website or URL to use that you will be asked a series of some questions about the webinar, and then Carrie will be sending you out a certificate. So thanks again in advance for your time and your commitment to really improving our risk adjustment and CPT II coding for the network. Next slide. If you have any questions, comments, concerns, or criticisms, please feel free to reach out to me. However, specifically for any questions related to content of this webinar, we will not be holding a Q&A this session, just because of it is such a content-heavy webinar that if you have questions, please email them to me and I will distribute them to the entire group. Again, first name donna.milovitz@steward.org. So with that, we'll take the next slide. And it is my really very big pleasure to introduce Tasia Henke to all of you, who will be talking about CPT II coding this morning. Tasia is a proven quality leader with several years of experience across many facets of healthcare, including acute patient care, first responder, and health plan operations. In 2004, she began working with Steward at Health Choice Arizona as a claims trainer. She moved into claims operations management in 2008 as a claims supervisor, and then transferred to the quality management team as senior management of accreditation in 2013. In 2020, she took on the additional role of senior quality manager for Steward Health Choice Arizona and Steward Healthcare Network ACO quality in the role of senior quality manager of quality programs and clinical reporting. Concurrently in 2011, Tasha also received her credentials as a certified professional coder through the American Association of Professional Coders. From 2017 to 19, she successfully led the Steward Healthcare Network organization to successful awards of NCQA Interim Health Plan Accreditation for all of Health Choice health plan products. And in late 2020, she helped secure our healthcare network's most recent NCQA award of credentialing and re-credentialing. She is a content expert on CPT II coding, and it is really my pleasure to hand off the baton for her to educate all of us a lot more on CPT II coding. So, Tasia, all yours.
Good morning, all. Thank you for joining us today. It's my pleasure to visit with you this morning on CPT II category coding. Some of the things I'll be covering during my conversation with you this morning include what are CPT II codes, which payers allow them, which gaps can be closed by using them, and getting kind of measure specific, what documentation / code to close the gap. Next slide, please. So what are CPT II codes? Basically, it is a quality reporting coding set that is produced by the American Medical Association, who also owns CPT I category coding, which the coding community as well as their providers are aware. That's how you get paid. Basically, CPT II codes really delve around quality management and showing that you completed the requirements needed to close a gap in care. They're basically non-reimbursable tracking codes, which helps us within the Steward organization facilitate data collection for the purposes of performance measurement. When we use these codes, it decreases the need to request a member's chart for the same information. I can't say we can make that happen in all cases, but for the majority of our payers, they are pleased when we do submit a CPT II code through the claim. You normally will close the gap in care right then, and then we don't come back and bother you guys at the end of the year and say we need a chart. Additionally, capturing this data helps us to drive our performance improvement. This is where we partner with you through the ACO within your practice to help you drive gap closure and to ensure that your patients are getting the care that they need. It directly drives star ratings. And we use this information to help us determine interventions and eventually subsequent increased performance. CPT II codes are billed on a Form 1500, just as you would bill a CPT I code. They normally describe clinical components, which are normally included in the evaluation and management or clinical services and are not associated with any relative value. And finally, we recommend that CPT II codes are billed with a $0 charge. Next slide, please. So which payers allow CPT II codes? Within our region of Arizona and Arizona and Utah, I've provided some of our regional commercial Medicare and Medicaid payers who are contracted with Steward Healthcare Network, who have confirmed the use of CPT II codes in order to close certain gaps in care. In Arizona, some of those would include Health Choice Arizona, Health Choice Pathways, which is the Health Choice Arizona Special Needs Plan, Humana, United, and then within Utah, Health Choice Utah Medicaid, Health Choice Generations Utah Medicare Special Needs, Cigna Commercial, Regent Commercial Medicare, and then again, finally, Humana Medicare Advantage. Next slide. So what gaps can we close by using these CPT2 codes? We've identified approximately 10 to 11 outcome measures, which we find that the use of CPT2 codes can help you close quite quickly, simply by affixing the CPT2 code to your claim and then ensuring that you're following up with appropriate documentation. Some of those include controlling blood pressure, and then for your diabetic patients, also the same measure of hemoglobin A1C screenings, and then good control and poor control measures. Please note, one of the things I've identified during my CPT2 gap analysis was that the CPT code 3045F was retired effective date of service January 2020, which means that you could use it, still use it through date of service 12/31/19, and it was replaced by more specific codes 3051F and 3052F. Please review these and ensure that you're affixing the appropriate code, which reflects the hemoglobin A1C result that you're billing. Diabetic eye exams is another example. Go ahead. Diabetic neuropathy, care of older adults, and medication reconciliation. Next slide, please. So I'm going to kind of want to dive in a little bit on how to close gaps using your CPT2 codes as far as from a measure-specific view. So for controlling blood pressure, what we would need to see would, of course, be the CPT2 code billed on the claim, the date of diagnosis of high blood pressure, or excuse me, hypertension, or DM2. If multiple blood pressures are taken on the same date of service, it is okay to use the lowest systolic and the lowest diastolic. They do not have to be from the same reading. And then finally, blood pressures that are taken on electronic devices and transmitted to the provider remotely are permitted. Documentation must state that the blood pressure was taken by an electronic device and interpreted by the provider. Please note, this includes patient-reported blood pressures. The one thing that they cannot do is provide a blood pressure reading that they've taken with a blood pressure cuff and a stethoscope. Manual readings are not permitted to be patient-reported. Below are the specific CPT2 codes that you can use to report this measure. Next slide, please. Hemoglobin A1C. Again, please affix your CPT2 code to your claim. You want to identify the most recent A1C that was taken during the measurement year 2020 or subsequent measurement year. Your claims or your claim or your supplemental lab data. And then you want to, again, ensure that your medical director documentation includes both the date and the result of the most recent hemoglobin A1C test. Next slide. Moving on, neuropathy screening. There's a couple of ways we can do this. Number one, we want to ensure that we see a diagnosis of diabetes on your claim, as well as the appropriate CPT2 code. And then we also need to see within the medical record evidence of one of the following. You can also do this through, of course, claims data, documentation. You can either use your CPT2 code, or you wouldn't want to see documentation of neuropathy screening or monitoring tests like microalbumin, which needs to include the date performed and the results, or neuropathy is evidenced by any of the following diagnoses within the measurement year. For example, diabetic neuropathy, ESRD, proteinuria, albuminuria, etc. Oh, let me also point out another great way that you can close these is the use of CPT2 code 4010. If your patient is on ACE or ARB therapy, be sure that you document that very clearly within the medical record. You can actually close the gap using the medication. Next slide. Diabetic eye exams. We really encourage everyone to encourage your patients to get their diabetic eye exams in the measurement year. Within your documentation, we would need to see a diagnosis of diabetes, CPT2 code, documentation of patients who've had a diabetic retinal eye exam during the measurement year to include the results and data service, or you can document a negative retinal eye exam, i.e. no retinopathy, that's from the prior measurement year, like 2019, which also needs to include the result and data service. Please note that the retinal eye exam must be performed by an ophthalmologist or an optometrist, and that's okay. If they're sending you their findings, you can document them as you reviewing them and discussing them with your patient. So moving on. For elder population, care of older adults measure actually is divided into 3 or 4 submeasures. I have 3 that I'd like to address today. Pain assessment. We need documentation of at least one pain assessment that was done during the measurement year, which includes documentation that the patient was assessed for pain, which may include positive or negative findings for pain, including the date of assessment, as well as the results using a standardized pain assessment tool. Moving on. Functional status is another one. You would want to, again, document at least one functional status assessment was performed during the measurement year, which includes a notation that active activities of daily living were assessed, as well as instrumental activities of daily living were assessed, and then finally the results of your assessment using a standardized functional status assessment tool. Please note that it is very important that you document the date of the assessment, the result, and the type of test, standardized functional status assessment tool that you use to gauge your patient's outcome. Moving on. I provided just a list of some functional status tools that for your review. Next slide. Another biggie is medication review. As we all know, medication reconciliation and medication review are very important, especially when a patient has multiple providers that they see, and maybe they have several chronic conditions, and everyone is prescribing something, to treat that specific condition. Well, as you know, that there are some medications that don't work well together, and can actually cause an adverse effect to the patient. So we recommend that the following is documented by either the prescribing practitioner or clinical pharmacist during the measurement year, at least one medication review, as well as the presence of a medication list within the medical record. Please document the date of that review and ensure that your list is contained in the medical record, or it will not count. Additionally, a little coding tip for you. Use both CPT2 codes 1159F and 1160F when billing medication review measure. This 1159 just says that you did the review. 1160 said you reconciled the meds. Next slide. Finally, medication reconciliation post-discharge. If you have a patient that you have discharged from an inpatient stay, it's from an acute or non-acute inpatient setting, if you document, if there's documentation provided by the prescribing practitioner, clinical pharmacist, or registered nurse, anywhere from the date of discharge through 30 days after discharge, that will help us close a gap in care. Additionally, the documentation in the outpatient medical record must include evidence of the medication reconciliation and the date it was performed, as well as it needs to meet any of the criteria presented below. Next slide. Just a few reminders, maybe to help you as you are affixing the CPT codes to your claim. When you are visiting with your patient and or looking at what your provider has handed you as far as your super bill or marked off in your EHR as far as closing the gap in care, always kind of take a look before the patient comes in and to see what kind of gaps are open, and then either address and capture them or dismiss the recommendations. And maybe it just isn't the right, clinically, maybe it isn't a good time for the patient to close the gap with that specific visit, but eventually, the end goal is we want to close as many as possible to ensure their continued health. Additionally, you want to schedule your physicals and annual wellness visits for any patient that are still needing quality measures within the measurement year. If a patient is due for colorectal cancer screening, please refer them for colonoscopy if indicated. Order a Cologuard, give them the occult blood testing card, whatever you feel is appropriate. If they're due for a mammogram, please give them a referral or an order and really point them that direction. And finally, when you ask your patient about what kind of testing they've had during the year as you're going through your checklist, please ensure that you know the provider that they had it, where they had it done. That's very, very helpful for us when we are tracking down records at the end of the year. And it just allows us to possibly avoid, an extra phone call, to looking for that information. That is the conclusion of my presentation, and I thank you for your time and your continued partnership in the overall success of our patients and their managing their health. Next slide.
Tasia, thanks so much. That was awesome. And just as a reminder for all of you, if you have questions, please email them to me, donna.milovitz@steward.org. We will address all of them.
Yourself, press star 6.
Number two. Can everyone please mute themselves? There's a lot of echo. Thank you. And then number 3, just as a reminder, we have our big Q4 push going on right now. And so using these CPT2 codes to help close those outstanding gaps in care is part of the bread and butter of what we do in terms of achieving our STARS rating, as well as hitting those thresholds for getting our quality dollars. So again, for those of you who have not muted yourselves, please do. Next slide, please. So we are now moving into risk adjustment. Oops. And once again, a lot of feedback. So if you could just mute yourself, thank you. And it's really my pleasure to also introduce Dina Post. Dina is the manager of risk coding and is a certified risk coder. She has her bachelor's degree in business administration. And Dina started her career in healthcare at a provider network within New England. At the Quality Care Alliance in Massachusetts. Her career with Steward began in February of 2013 as a local chapter manager and director in 2 of the Massachusetts markets, working on quality, care retention, and provider retention. In 2016, Dina was asked by Steward Healthcare Network medical director to move into the new role, focusing really on educating the entire network on risk adjustment. She now has a team of 14 risk coders who audit medical records and looking for any missed opportunities in risk adjustment diagnosis coding. I cannot impress upon you how important it is to ensure that we are adequately capturing the medical complexity of our patients. And Dina's going to spend some time not only discussing that with you, but also sort of some additional tools in your toolbox to do that. So with that, Dina, take it away.
Thank you, Dr. Milovitz, and good morning from Massachusetts. So what I'm going to be discussing today is really, what is risk adjustment? Why is it so important? What are, the documentation guidelines to make sure all of the risk codes are supported? Also, what are the best practices that can be done in each of your practices to make sure that everyone is aware, and, especially the provider, that there may be risk conditions that need to be captured for the year. And then also I'll run through, some of the most common risk conditions we see both in the Medicare population, the commercial population, pediatrics, and Medicaid. Next slide. Next slide. So what is risk adjustment? The most basic way to actually say it is that risk diagnoses codes help set the budget for our risk contracts. So it's a financial offset that recognizes that there are higher costs to caring for patients with these chronic conditions. It levels the playing field in all of our risk-based contracts, which I'll talk about on another slide, to perform against the budget. So risk adjustment depends on accurate reporting and capturing of chronic conditions by providers, whether that be, an MD, DO, NP, or PA. It could be any one of those 4. And capturing them on a yearly basis, so at least once per calendar year. And this information, when these risk conditions are captured, it's used to help predict costs for the patient for the following year for Medicare, and it's within the same year for commercial and Medicaid. So it's not just all about the budget, although obviously that's very important. But capturing a patient's chronic conditions on a yearly basis helps us identify within the network, but also, within the payers, who has a chronic condition that may need disease management programs. And we have those within Steward, but also the payers have those as well. Next slide. So these are our risk contracts. We have commercial, we have Medicare, that includes Medicare Advantage, and we have Medicaid risk contracts. So the Medicare risk contract, which many of you may already be aware of, is an HCC model, and that has been contributing to the overall budget within Medicare Advantage since early to mid 2000s. So with commercial, that actually came into place, with the ACA. The commercial and Medicare models are actually called the DXCG model. The DXCG model does not actually, they don't communicate all of the chronic conditions or acute conditions that have risk value. Only Medicare distributes every diagnosis that would actually increase your budget because the patient has that. Commercial and Medicaid, we use, because it's not reported by the payers, we use a Johns Hopkins model that's very similar. And we just kind of had to figure out, what are these chronic conditions that didn't already overlap with the Medicare population that we believe has risk value. Next slide. So how does that risk score, develop? How do we determine what the budget is? So the risk score is known as the risk adjustment factor, or RAF, for the Medicare population. It's known as a health status adjustment for commercial and Medicaid. So each patient has a risk score at base, which includes their demographic elements, age, sex, and whether they're dual eligible for Medicare and Medicaid. So they all start out with some kind of budget based on that information. And then every chronic condition or risk adjusting condition that's captured and submitted on the claim during the year increases that budget incrementally. So at the end of the year, a risk score is determined based on all those chronic conditions, and that risk score sets a particular budget for that patient. So each chronic condition, as I said before, has to be captured at least once per year to help set the budget, and failure to do so will result in a decreased budget, and whether it's the following year or in the year. So this resets yearly for all of our payers. For Medicare, anything you capture this year sets the budget for next year, and for Medicaid and commercial, anything you capture this year sets the budget for this year. So capturing a condition more than once a year is fine, and many times, a provider will need to assess that condition more than once a year, but it only counts toward the budget once. And chronic conditions, we tell providers that, the annual wellness visit or the physical is a great time to actually assess all of their chronic conditions. But there are times when it's appropriate during a sick visit. If that chronic condition goes into the medical decision making and treating the patient. An example would be if a patient comes in for a cough, any type of respiratory illness, and the patient has COPD. It's perfectly appropriate to capture that COPD in that visit. Next slide. So this is an example of minimal versus optimal documentation and coding and how it affects the budget. So this particular patient, she's a female born in 1934. So at baseline, she gets a risk score based on that. And then her clinical picture, she has diabetes, chronic kidney disease, stage 5, COPD, and congestive heart failure. So over to the left, you see that this patient came in for a visit, but only non-risk conditions must have been captured at this visit. And, hopefully that patient comes back, but you never know. So we got a risk score for that 84-year-old female, and she was dual eligible. None of the chronic conditions were captured. This just left us with that baseline demographic risk score and a total payment of $7,000. And just let you know, these values are for illustrative purposes only, but I got this from a Medicare Advantage plan. So it's very close to how it affects the budget. The middle column, some of the conditions were captured, but not to the highest specificity of what those conditions are. COPD was captured, And type 2 diabetes was captured, but without complications. And we know from the clinical picture there are complications due to the diabetes. So that actually left us with a total of $12,000 in the budget for that patient. Over to the right, all conditions were precisely documented based on the clinical picture. So COPD was captured, the type 2 diabetes was captured and linked to the chronic kidney disease. So there is always a causal relationship between type 2 diabetes and chronic kidney disease unless the provider states otherwise. So a coder would automatically link those if the provider hadn't, unless the provider says otherwise that the CKD is unrelated. But in this case, it was related. The CKD also needs to be staged, and stage, in the Medicare model, stage 3, 4, 5, and end stage all have additional risk value. Then you have the chronic diastolic CHF, which adds additional risk score. I'm not really going to go over the disease interactions. That's something that the payers do at the end of the year, and with congestive heart failure, it's more common in the Medicare population. Whenever there's a congestive heart failure and another comorbidity, they will add to the risk score on their own. But the provider doesn't need to link them. They just need to have been captured once at a visit throughout the year. So this leaves us with a total payment of almost $25,000. So you can see the between capturing and not capturing the most precise conditions that the patient has. This isn't the only thing that covers the cost, but it plays a big part along with premiums and other things that go into budget. Next slide, please. So I'm just going to go over documentation requirements. I went into a little bit more detail when I did a provider only, but this basically is a summary of what it all was. Next slide, please. So accurate documentation and coding. So providers must document and capture conditions only if it's addressed at point of care and clinically appropriate. So if they didn't talk about it at that visit, it can't be coded for or on a claim. If it wasn't documented, it didn't happen. We never want to encourage a provider to upcode. That's not what this is. This is about accurately coding what the patient has. If and when audited by CMS or another payer, we want to ensure that there's compliance in all aspects of the documentation and coding. And this is a legal, medical records are legal documents that need to survive both its subject and author. So continuity of care, I went over a little bit of this, but appropriate documentation and medical records help support referrals to other specialists. It may prevent errors or unnecessary testing if a specialist knows exactly the condition this patient has already been diagnosed with, and to the high specificity of what is known. And the medical record has complete documentation if the patient ends up in the hospital. So, any of the hospitalists or specialists there are aware of the conditions this patient has. Next slide, please. So CMS, and actually I will say all payers really at this point, require that every chronic condition be monitored, evaluated, assessed, and treated, and providers know that. In medical school, make sure your notes have meet. So providers really should avoid this type of language. Continue same, no change considered, and those are considered inadequate. And we want to make sure we're not just saying stable, because we want to know, okay, but what is the continued treatment plan? They want to know that it was assessed. but also that there is a treatment plan as well. And continuing same doesn't really tell us the same as what. We want to be able to know in that particular visit, what is the status. It does not need to be a paragraph by the providers. And we try to tell this all the time. I know it takes them long to input everything into their EMR, but, brevity is certainly acceptable as long as, the status and the plan is there. So if a patient has hypertension, blood pressure, good on lisinopril, 10 milligrams, continue low salt diet. That's perfectly acceptable as supporting documentation. Opportunities to capture conditions. I already went over, sick visit, but also taking height and weight at every visit. I know with EMRs now, that's usually what happens. But morbid obesity is a condition that is not being captured enough across our network, and I'm sure across many networks. And usually the BMI will actually tell you whether this patient has morbid obesity. Next slide. So just documentation tips for all practices and providers. Avoid homegrown abbreviations. So if ever audited, or, if my team is ever doing, some medical record auditing, just see if there's any education that needs to be communicated to providers. It needs to be a known medical abbreviation. And then document all cause and effect relationships. And this is more common, definitely with diabetes and any complications. So those cause and effect relationships really need to be captured within the documentation in the medical record. And then include all current diagnoses as part of the current medical decision-making and carry them to the final assessment. Example is we see providers documenting conditions in the HPI section or the exam, and they end up leaving it off the final assessment and off the claim. They should be getting credit for these conditions. They assess them in the HPI. As a coder, if I see, a condition documented in the HPI and there's enough support, even though it's not on the claim, I will add it to the claim, especially if it's a risk condition at this point, because we want to make sure that those are being captured. But it really starts with the provider. And then document status codes. So conditions, status codes like amputations, ostomies. Amputations don't go away. I get told that by providers consistently. Why do I need to capture this every year? It's because the budget resets to baseline every year. And the payer needs to know that this condition exists on a yearly basis to set the budget. And hardest one for me when speaking to providers, because I know they use that past medical history, and they may put chronic conditions that still exist, but only documenting diagnoses as history of a past medical history when they no longer exist. It certainly makes it easier for coders and billers. Next slide. So these are some best practices that can be done in offices from a pre-visit planning standpoint and post-visit. Next slide. So days or the morning of a patient encounter, clinical review could include, but is not limited to, lab results, looking at prescriptions, looking at past medical history, looking at recent physician or specialist progress notes, just to see if there's anything in there, any conditions, related to lab results, prescriptions, or recent specialist visits that may inform a condition that has not already been captured or may need to be recaptured in the current year. So that review, and whether it's done by, an MA or, anyone or the provider, I know some practices, may have a performance liaison, some may not, but that information can be done within the practice. We want to communicate those findings with the provider before the provider sees the patient. And it's, there are places we can put that within Athena. Athena has a risk tab that's off the problem list that can actually show chronic conditions that that were previously captured that may need to be recaptured for the year. Or, the provider may like the yellow sticky or that exclamation point in Athena to have that information put there before the visit happens. Next slide. So for post-visit, once the patient is seen and the note is locked, we just want to make sure all risk-adjusted conditions were captured using the most specific documentation and clinically appropriate diagnosis code. So the provider may have captured, congestive heart failure unspecified, but there's documentation there that supports diastolic. So we want to make sure that that coding matches what the documentation is. And of course, as I said about, the HPI section, if a risk adjusting condition was documented and coded appropriately, make sure it ends up on the claim. That's the only way the payer knows that the patient has this condition. And if a risk adjusting diagnosis code was not documented and coded appropriately, and it still is a clinically appropriate condition, then we want to make sure the provider is aware that this should be captured at the next visit, and it really should be within the same performance year, so, it helps set the budget for that patient. Next slide. So these are the next slides are examples of chronic conditions that we see within these models. I'm not going to go over every one of them, but these are the most common Medicare risk adjusting conditions that we see. I just want to note that for CKD, new ICD-10 coding guidelines as of October, they split stage 3 into 2 different codes, adding an additional number, a fifth, 3A and 3B. So depending on what the GFR level is. And we have a one-pager that's going out to all providers and staff. I know it went out to providers last week, I believe, or the beginning of this week. So more information on that. And morbid obesity and major depression are 2 of the most common conditions that are not being captured or recaptured on a yearly basis. Next slide. So these are just more of Medicare, but I also want to mention that alcohol dependence or any type of drug dependence, even in remission, are still have risk value, even in remission, and affect the overall health of the patient. So it's still important to capture that, even if a patient's been sober for 5 years. That is considered remission. Next slide. So these are some commercial and Medicaid conditions. Next slide. I actually already went over this, so I don't think I have to go over it again. You know, for commercial, we use the Johns Hopkins ACG system right now because the DXCG model, which is the model that is used by our commercial payers, does not communicate all of the conditions, the thousands of conditions that have risk value. Next slide. So just some examples of commercial and Medicaid diagnoses that are not in the Medicare model. There is a lot of overlap between Medicare and Medicaid and commercial, but there are some conditions that wouldn't be. And coronary artery disease is one of them. So in the Medicare population, it has to be with angina, but in commercial and Medicaid, but this is why I tell providers to not focus much on what are the conditions that have risk value. Just capture the chronic conditions to the highest specificity on, the information that you have. Next slide. So I know there's a lot of pediatric within your market. So I think I actually have 4 slides. Next slide. So these are respiratory and cardiovascular cardiology conditions that have risk value, at least within the Johns Hopkins model, and we believe within the DXCG model. Asthma is a big one, obviously, for pediatrics. And of course, trying to be as specific as possible and not just consistently using unspecified. Next slide. These are common psychiatry and behavioral health conditions. So this is especially important in the Medicaid, with the Medicaid patients. Behavioral health conditions are, even have more value within the Medicaid population because we see it a lot within the Medicaid population. And there's so many more, and behavioral health disorders as well. But opioid use is another one, which I'm not sure, I don't think I have it on here. But opioid use abuse is, a condition we just, found out based on some analytics that is not being captured enough. So I actually have a 2-pager that I'll be able to send you, Dr. Milovich, to actually communicate or send around to staff providers that we just finished actually this week. Next slide. These are just neurological and rheumatology conditions for pediatric. Next slide. And these are genetic conditions within the pediatric population that should be captured consistently on a yearly basis, as long as it's still, active condition, regardless of, whether it's been through birth or not. It should be continued to be captured. Next slide. And then to end, these are some key takeaways. All providers are encouraged to document, diagnose, and capture appropriate chronic conditions at every encounter to ensure the patient's health status, but it really is only necessary once to help set that budget. It only counts once per year toward the budget. And providers are encouraged to integrate pre-visit and post-visit planning into their practice, whether that be the MA or someone else, just to make sure that the provider is aware, okay, what are the conditions that are chronic that we know that need to be addressed. And even if it's being monitored or treated by another provider. Assessing it is important from a primary care standpoint. So there is a record that has all of their conditions in one place. And a provider could just say, you know, atrial fibrillation being monitored by cardiologists, you know, on, you know, whatever medication they are on for that AFib. That's certainly enough to say that they're being monitored by another physician. They have an appointment with the cardiologist, you know, next month. That's enough to support, you know, conditions that they may not be treating themselves. Well, I shouldn't say any questions. I know we have a few minutes left. Dr. Milovitz, are you still on the line?
Yes, I am. So first
Okay.
of all, thank you so much, Dina. That was fantastic. I always learn something new whenever I listen to you and to Tasia. So again,
Thank you.
I want to just wrap up by saying that if you do have questions, I know we don't have time to open it up for a Q&A, but please send those questions to me electronically at donna.milovitz@steward.org. I will make sure I get it distributed to the entire group. Number two, thank you so much for your time and for your partnership in caring for all of our patients within Steward Healthcare Network. Just to remind everyone that here is the web address and the URL code for you to receive your CME or MA credit points for this, as well as your CEUs if you are a certified coder. Your time is valuable, and you should at least get credit for this. And then lastly, just to say that, you know, this is the bread and butter of our risk-based contracts, is documenting the quality measures, making sure that we are doing those things that have proven value to improve our patient lives and their health outcomes, and that really to document the medical complexity of the patients that you see, so that we get adequate payment to be able to care for them. All of those things working in conjunction with care coordination really help drive that that value-based care that we provide to all of our risk lives. So thank you for your time. Thank you for your partnership. I hope this hour of your time has added value to all of you. And yes, I will send out the slide deck. I will send out the updated addiction RAF scores for all of you. That is new from Dina's team, as well as the additional content for these 1 to 2 pages for not only the CPT2 coding, but also for the risk adjustment scores. Have a great day. Please stay safe out there. Make sure that you mask and social distance and practice good hand hygiene. And I look forward to collaborating. Have a great day, everyone. Thank you. Bye now.
Thank you.
Thanks.